For coming to the Health and Wellbeing Board here at County Hall on Thursday the 14th of April 2022. Lovely to hear about everyone's gardening plans in advance of today for the bank holiday weekend. Okay, item 1, apologies for absence. Do we have any apologies for absence?
Yes, apologies from Julie Boyack, Kath McAvoy-Carr, Rick O'Farrell, David Thompson and Wendy Patterson.
Thank you very much. I can't see any more. I think Guy Renner-Thompson, was he on that list? Well, I can give his apologies. He put them to me earlier. Okay, item 2 is the minutes of the meeting of the Health and Wellbeing Board held on Thursday the 10th of March 2022 to be confirmed as a true record. Can I? Yes, Councillor Simpson.
Chair, I was at the last meeting, but it's not recorded.
Okay, can we update that? Other than that, are we happy to accept them as a true record? Agreed. Thank you. Item 3, disclosure of interest. Any members needing to declare an interest? No, that's fine. Okay, so I'll go on to item 4, which is living with COVID. It's a presentation by Liz Morgan, Interim Executive Director of Public Health and Community Services. Over to you, Liz. And I suspect there might be someone else as well.
Yes, Community Services, yeah. So, since we last met, we have had a whole raft of guidance which has come out about how we live with COVID. So, this report really is intended to provide you with just a whistle-stop even tour of the main changes, but also some recommendations to the board about the future governance of and management of the pandemic in Northumberland. So we estimate that, or the ONS estimates that in the week up to the 2nd of April, we've still got over 4 million cases of COVID in the UK. So, you know, you could be forgiven for thinking that this isn't a great time to change our approach. But what we do know is that this pandemic will just continue to take its own course, and we can probably expect the unexpected for quite some time, probably the next 18 months to 2 years. So there really is no right time to make this change. But I suppose the point is that we're heading into spring, where people will hopefully spend more time outside. Despite the high prevalence, we're not seeing the hospital admissions and severe disease and deaths that we saw in January 21. That's not to say that our hospitals are not under a huge amount of pressure, because they are. And we've got a lot more tools in the box than we had even a year ago. I think the other thing that we need to reconcile ourselves to is actually that the current approach is just not sustainable, and certainly the public health impact of some of the interventions just wasn't stacking up. So we did need to change our approach. So this Living with COVID document was released in February, and it does really shift our approach to managing COVID more like we would other respiratory infections like flu, although they are actually completely different infections. So the principles of living with COVID are around encouraging the public to maintain those safe behaviours, protecting those most vulnerable from severe disease through vaccination, through targeted testing, through the new treatments that we've got available. It talks about maintaining resilience so we can respond to surges that will come up in the future. So how are we going to surge testing? How are we going to surge vaccination? What are our surveillance mechanisms going to look like? And then there's also a focus on research and development. So, as I said, we had a tidal wave of guidance, mostly on the 1st of April when testing stopped. You'll be pleased to know I'm not going to go through any of that in any detail, but I'll just go through a couple of areas. So the first one is around changes to testing, and there have been huge changes to our approach to testing, because free testing for the general public has largely ceased. So the strategy is much more targeted, and we can think of that in terms of testing for care, testing to treat, and testing to protect. So testing for care is really a mixture of PCR and lateral flow tests, and where there is a shift to the use of lateral flow tests to identify infection in symptomatic people, not just asymptomatic people. And we shouldn't underestimate the impact of a positive test result in terms of management in the hospital environment. So test to treat, that's all about high-risk patients in communities, so those people with certain types of cancer, with kidney disease, people who are on certain types of chemotherapy. So if those individuals are symptomatic, then they'll use a lateral flow test to identify whether they've got COVID or not. They report the result, and then they will be fed into the pathway that will hopefully connect them to the antivirals and other treatments which are available to that group. And then the third bit is around testing to protect. So this is the continuation of the asymptomatic testing that we have been doing, some of which is only during periods of high prevalence, but at the moment that's for adult social care, care homes, social workers, hospice workers, the NHS or public-facing staff in the NHS, some prison staff, and the purpose of that is to mitigate the risk in settings with vulnerable individuals and where the risk of transmission is high. So in terms of surveillance, clearly the changes in testing have had a knock-on effect on the number of cases that we're seeing and the case rates. So that's no longer as reliable a measure of how much infection is around. So we have got this ONS survey which tests tens of thousands of people every week using a PCR test, and it is retrospective, so the most recent data, as I said, was the week ending the 2nd of April, but what that's telling us is that in that week we still had 1 in 13 people in England who would have tested positive at any one time if they'd been tested. And that's pretty similar to the week before, actually, which does give us hope that actually at least the rate of increase is slowing. And we'll hopefully see that tipping over when the date is released again tomorrow. In some age groups, it's levelling out. In some age groups, the prevalence is continuing to increase, but again, we'll have a look at the trends when they're released tomorrow. Now, that ONS study excludes care homes and healthcare settings. So we've got another couple of studies, the Vivaldi study, which is looking at COVID-19 in care homes, and the Siren study, which is looking at infection in hospitals and healthcare workers. So we've got those two studies. We have still got the ongoing testing programs. We've got all of the inpatient testing, which is still going on. And, you know, we've got really good networks locally, regionally and internationally, actually. That was why we were able to pick up the variant in South Africa so quickly, because we had those really good relationships globally. And we've also got a really good local intelligence network. So, you know, if the Trust sees cases increasing, you know, I have every confidence that they will let us know that that's the case. And in terms of advice to the public, well, that has shifted away from being COVID specific and shifted towards being much more general. And that's really important, because the reason why we saw such a downturn in flu and a range of other respiratory infections over the winter was because of those simple actions that we take to prevent COVID, also prevent a whole range of other respiratory and other infections. So the advice to the public is very much around getting vaccinated, and not just the COVID vaccine, actually taking advantage of all of the vaccines that are available in the vaccination programme. So that could be flu, that could be pertussis in pregnant women, it could be pneumococcal vaccine, and shingles in older people. So it is about promoting all of the vaccination programmes that we've got in place. It also really focuses on the importance of ventilation, focuses on the continuing the basics, so hand washing, respiratory hygiene, and finally about just choosing to wear a face covering when the prevalence is high and if you're mixing with people that you don't ordinarily mix with. And then the other bit of guidance is really, again, generally around respiratory infections and just encouraging people to stay at home if they feel unwell, particularly if they have a high temperature. I was looking at quite an interesting bit of research earlier in the week, which talked about the impact on productivity of absenteeism and presenteeism, and actually for every day that you lose from absenteeism, you lose a day and a half from presenteeism. So we really need to be encouraging people to work from home if they can, if they are feeling unwell. I think there are a whole load of opportunities that we can pull out of the last couple of years. So obviously the vaccination programme has been an absolute success, and we've gone to a huge amount of effort to promote uptake particularly in underserved communities. So we really need to look at what we have put in place to support those vaccination programmes in those communities and look at how we can translate those across to other programmes where the uptake might be low. Infection prevention and control, that's something collectively we've put a huge amount of time and effort in. We've worked really hard across the adult social care team, across the public health team, colleagues in the CCG, the Trust Infection Prevention and Control team, and with care homes and domiciliary care providers to improve infection prevention and control processes in those settings. And we really need to continue to maintain those relationships and keep IPC at the forefront so we can reduce the transmission of COVID and a whole range of other infectious diseases. So the proposal is that we develop an IPC strategy which takes into account of care settings and providers, but also schools and workplaces, and particularly for workplaces, because actually we need to shift this culture change away from one which encourages people to come to work if they're not well. The Health Protection Board has been fantastic in terms of sharing information and managing the pandemic at an operational level, but actually we really need to pivot the Health Protection Board to consider wider health protection issues. And then I think the last opportunity, or the final opportunity that I've put up here, is the work that we've done, not just across that group of 7 local authorities, but actually across the whole of the North East. And there are opportunities there to work together around shared goals, short to medium term priorities, and next steps, particularly in terms of addressing health inequalities. I think comms are going to be really important going forward. We've had a very successful communications programme based on behavioural insights and, appealing to what is going to change behaviour in particular groups. And I think there is an acceptance that they resonate and they're trusted more at this stage of the pandemic if they come from our local NHS partners and the local authority. So we need to make sure that our communications are simple, that they're consistent, that they explain why we're making this shift, and they need to be really nuanced for different communities. And we need to really make sure that we understand the answer to the question, what's in it for you, for our diverse communities? And that's what that behavioural insights work does. So I think the key messages then are that the next 2 years are going to be a little bit bumpy. We can expect further waves of variants. They may be more transmissible. They may or may not cause more serious illness. There is absolutely no certainty except uncertainty. Vaccination continues to be the key, and that's why Omicron in the UK was associated with generally milder illness and lower levels of hospitalisation and serious illness. That wasn't the case elsewhere, so the vaccination programme has been absolutely critical. We are probably going to need regular, perhaps annual vaccinations, and we need to maintain those high levels of vaccination uptake, which I think is going to be quite a challenge. In terms of resilience, we know that those waves can happen very quickly, and as organisations, particularly the local authority, we need to be prepared to respond quickly if required. That might include supporting mass testing, vaccination, contact tracing, and an outbreak response. And also, the final point really is just about emphasising the importance of those safer behaviours, because that is really going to make a significant impact if we can maintain those. And then just some final recommendations for the board. So the proposal, because the national contain framework has now been withdrawn. So the contain framework was that document which sort of put in place the local, regional and national arrangements and how we work together. But actually that contain framework has now been made redundant. We're not going to be maintaining a COVID-19 local outbreak management plan, because we're shifting away from managing COVID-19 in isolation to managing respiratory infections more generally. So the proposal is that we withdraw the local outbreak management plan. The second recommendation is linked to that, is about standing down the Health and Wellbeing Board as the COVID-19 Control Board and the Engagement Board, because that was part of the governance arrangements around the contain framework and the local outbreak management plan. And then the third recommendation is around maintaining our Health Protection Board. We had a really useful discussion at the Health Protection Board on Tuesday about what that board could do going forward. I think there is still some work to do, clearly, around continuing to manage COVID-19 in our communities, but there was broad agreement that there would be value in having a health protection board which looked at infectious diseases more broadly and focused perhaps on other areas of health protection activity, like healthcare acquired infections, immunisation uptake, cancer screening uptake, and those sorts of things. Accepting that actually clearly we don't want to duplicate activity. I think there's also some work to do about future pandemic planning. So that's my report finished. But I'd be very grateful for your views and support of those recommendations as a board.
Okay, I've got Jeff Watson, Councillor Jeff Watson.
Thank you, Liz. Very comprehensive as usual. 2 questions. 1 in 13 people you said have got COVID, we think, in the UK. So what is the current R factor? Is it still? Are we still measuring that? And the second one, that sounds as though that might have been an awkward question. And the second one is, you mentioned it says in there that if you test positive, stay 5 days in. In brackets, if you can. Does that really mean it's not necessary then?
So, okay, so the first question about the R factor, to be honest, I don't look at that very often. What I'm interested in is the levels of community transmission in Northumberland and whether, from the ONS survey and previous case rate data that we had, whether cases are going up or not. That's generally what we base our response on. So actually, I don't know what the R value is at the moment. And then the second question about staying at home. There's no statutory requirement to self-isolate now. I think the problem that we have, and it goes back to this issue about inequalities, is that there will be lots of people who will be able to work from home, but there will also be lots of people who are working in less secure jobs, who are working in jobs which don't have particularly generous benefits packages, who actually can't afford to stay off work. So that's why the guidance says, stay off work if you can, because we accept that actually a lot of people just won't be able to do that. I think there is something about taking the opportunity to really look at the health, sort of sickness benefits packages which are available, and looking at whether they are fit for purpose. But obviously, that's for the government to look at.
Okay, thanks for that. I've got a question from the lady here.
Thank you. I'm absolutely delighted with you, the third recommendation about the Health Protection Board and its widened remit, because we know some of those areas around immunisations, healthcare acquired infections and cancer screening. The gaps in those affect some of our most vulnerable and deprived populations. And I understand your comment about duplication, but that board has been so powerful over the last 2 years. I'm really delighted that that remit's expanded and it's going to look at that work, because for the best will in the world, we still haven't cracked those areas.
No, I would agree with you, and I think a lot of the principles, the interventions that we've applied to the COVID vaccine, we can apply to other programs, not necessarily actually even just vaccination programs, but the use of community champions, the use of trusted voices. I think we're much better informed about what works and as importantly what doesn't work than we were 2 years ago.
Okay, yes.
Yeah, thanks very much. Liz, I was really interested to hear the issue around presenteeism versus sickness absence. And I don't know whether this question could be answered here today, because I'm not sure there's representatives, but prior to COVID in the NHS had targets to reduce sickness absence, and quite stringent targets. And the result there was that staff who didn't meet those targets actually went through a disciplinary process. And I just wondered, I mean, I'm very out of date now in terms of the NHS because I don't work in the NHS anymore, but I just wondered whether COVID had made a difference to that, because there was an impact on that, even before COVID, in terms of people coming in when they were still sick. So has COVID shifted that? And if so, probably based on that analysis that's been done, why not really?
I mean, I'm probably not best placed to talk about the NHS, but interestingly, we were just talking about that at a meeting prior to this one. And, we recognise that actually if we're trying to encourage people not to come into work if they're unwell, particularly if they've got a high temperature, then there is a consequence to that which could impact on, sickness absence and sickness benefits. And we need to be very aware of what the impact of that is and make sure that people aren't disadvantaged because we're trying to shift the culture that we've got at the moment. But I don't know whether perhaps Graham or Siobhan or Jane can talk about what's going on in the NHS.
I think some of the bigger organisations like Northumbria or the Ambulance Trust would be better placed to talk about their approach. I haven't observed any changes in how people are presenting in primary care to do with their sickness, really. But I think certainly there are higher background rates of absence still in the trusts.
Yeah.
I was going to highlight, actually, thanks for the report, I would support you in what you're suggesting we do now, but we must be careful not to assume that it has gone away. COVID is still putting a big strain on services, primary care, secondary care. We're not seeing the tragic outcomes that we were, which is excellent, but we're still seeing an awful lot more activity that we didn't previously have to deal with. So there is a strain, and it's not gone away. So.
Yeah, and I think, obviously the pressure isn't just about the levels of activity. The pressure is also related to the number of staff who are off because they have got this infection. And actually, anecdotally, I am picking up that this time round it's lasting for longer. Even fully vaccinated people are really quite unwell. So it does, the impact of the virus does shift with each variant.
One more point on that, just in terms of recovery. We are monitoring recovery really carefully, but there were some really ambitious targets for recovery around elective care and services, and there was a rider on those assuming COVID rates reduce. And actually what we're not seeing is COVID rates reducing, but the expectation on services to recover, I think, is still very high. And therefore, we just have to continue to watch that and do all we can. But we are working hard with all the providers around how are they managing things like the waiting lists and things like that. And that problem has not gone away.
Okay, have we got any more questions? I can't see any more questions, so what I'm going to do is I'm going to move to, we've got those 3 recommendations which were on the previous slide. Are we happy as a board to accept those 3 recommendations? Yeah. I'm seeing that, I'm not seeing any dissent to that, so that's great. Thank you very much. Thanks for your presentation, Liz. I'll go to the next item. It's yourself again, Liz. It's to receive a verbal update and presentation on the Health Inequalities Summit.
And I'm going to pass immediately that over to Jill. Thank you.
Morning everyone. So hi, I'm Jill O'Neill, I'm Interim Deputy Director of Public Health. You do have a longer slide set in your packs, and I've actually just condensed the slides just to talk through this morning in the hope that we can spend more time discussing next steps, if that's okay for everyone. So really what we want to talk about is the Inequalities Summit that was held on the 25th of March, ultimately working towards an inequalities plan that we would like to produce for the County of Northumberland. This was a call to action from the system leader, and hopefully there was many of you around the table. Unfortunately, we did have to restrict numbers because we wanted to be COVID safe, but we are making a commitment that there are going to be subsequent locality level events to make sure we do get a broader conversation happening across the whole of Northumberland. So as I say, this was a call to action from the leader coming out from the depths of COVID as we still manage it, as we've just talked through in the last presentation, but more tipping towards recovery, understanding where we're at from an inequalities perspective. So it was badged as a Thriving Together event. It wasn't badged under any one particular organisation, because the whole premise was that this was about the system moving together with a real ambition to try and bring all of our different inequalities plans together. All of us have got different targets, priorities, ambitions. We do have the joint health and wellbeing strategy as our overarching, but again, this was a bit of a reset and a bit of a thinking differently, because we've learned so much during COVID around the power of community, and that's really emphasising the strengths of community as well. We didn't want this just to be a data set orientated event. We want it to be more of an immersive experience where we did bring out lived experience of different parts of our communities to understand, again, from a strengths-based perspective, how people are currently living, the context of their lives, and sharing examples of best practice. So we had the likes of British Vault in attendance, who've got a very strong social value and charitable arm, which is about bringing local talent through, training local people for local good quality jobs. And that's they're not the only example, but they particularly stood up and talked with us. So we tried to have a focus on the key underlying factors that can lead towards that gap in life expectancy and people dying too young, and that is about employment, and it is about skills and education. And then we did really try and bring key leaders and key voices to the event, which was Cormac Russell, who's an international speaker on asset-based community development. He's also, as well as working internationally, working with the likes of Bristol at the minute and Leeds as well. So as he was a live feed from Ireland, and the tech didn't let us down, which was a relief on the day. But he was there, so we'll talk about that. And we had overarching facilitator Professor Chris Bentley, who was the director of the Health Inequalities Group and the National Support Team, and he's the author of the Population Intervention Triangle. So I'll just briefly go through some of the things that we covered and what the emerging priorities were that we'd like to bring to the board today for further discussion and recommendation. So as I mentioned, Cormac Russell, who's an international expert around asset-based community development, he was really focusing on why there is benefit in the opportunity to focus more on working with, but ultimately how things can be done by community. We tend, as organisations with the best will in the world, to quite often try and work to or do for our communities, and actually it's a really big shift for us to start to think think, well, how can we work alongside and how can we enable communities to do things for themselves? And this is about participation, not just representation. So Cormac talked to us about, can we hang every consideration on 3 core questions? What is it that communities can do best? What do communities require some help with? And then what do communities need outside agencies to do for them? So we're by no means saying that let's all be stand off and this is all about communities doing things. We've all got a role to play without a shadow of a doubt. And that's where the next part comes into play, which is Chris Bentley's work. And again, the detail is in your slides pack. But Chris Bentley's programme is all about how we think about things from a civic level responsibility perspective and what's our best levers to utilise all of the tools in our toolboxes, but then also how do we best enhance services so they're there at the right time in the right place, but equally, what is it that can come from community? And it's only when we get those 3 component parts working at the same time will we truly get place-based working, and that's where we can understand how we can focus on inequalities, but from a strength-based perspective, and that's the critical factor. So Chris talked about working across the seams, so how do communities work with services, how do civic level responsibilities play into community? And he talked about the no man's land, but actually we can fill that no man's land, not only with the voluntary community charitable sectors, but actually with community themselves. And we heard one example of the Forget Me Nots, which is an association in Blyth, which is women that set up a programme because they wanted to do something themselves for their community. And with a small grant, micro grant funds, they were able to really start to empower many more people within that community. So that's the premise of the 3: civic, community and services. We were in workshops asked to look at how mature we are in relation to those themes and working across civic and community and services and community. And the table discussions highlighted from moving from emerging through to developing, maturing and thriving, that actually when we held a mirror up to ourselves and we were really honest, we said actually we're probably emerging to developing in relation to thinking as a whole system, how we best work from a community-centred perspective and how we maximise the opportunities we have of our civic responsibilities, services and empowering communities. But that's not to say we haven't got absolute pockets of maturity and thriving examples, and it's about finding those signature stories and really building on them. And then the 3rd workshop that we ran was trying to pull all of the information that we'd had over the course of the day and say, if this is all about us coming together and pooling what will become our inequalities plan and having a few key ambitions that have longevity to making a difference ultimately in outcomes and opportunities for our residents. And the summit attendees and delegates highlighted that what's critical is improving our data and our insights. And that's about having that citizen's voice as an equal weight to the data and seeing that richness come through, but very much sharing our data across organisations so that we can have a much more holistic understanding of what's happening within our communities. It is about looking at all different ways that people are currently understanding community-centred approaches, but let's all try and come up with a common understanding and upscale that community-centred approach, utilising Cormac's 3 questions that I'd highlighted earlier. It is about aligning our organisations and our resources, and that's not just from a funding perspective, that's from a cultural perspective, that's from a workforce perspective, and that's from how are we looking at performance and metrics and outcomes perspective as well. And then we ended up highlighting that there was 4 key priorities in all of this, and that's how do we look at everything through an inequalities lens, ultimately to how we are levelling up and how we're closing that gap that we currently have within some of our communities. And the challenge for us is to take all of that into the next steps and to put detail around that so we can measure our maturity now and where we want to be going forward. So really, taking all of that on board, thinking about Cormac's 3 questions, thinking about community services and civic responsibilities, we highlighted that we wanted to come to the Health and Wellbeing Board for further discussion about the emerging priorities that were evolving, ideally to agree to establish a task group that would sit under the Health and Wellbeing Board to progress, as I mentioned at the beginning, the locality events to further the conversations, because this was just the start of talking differently about inequalities, but ultimately working at pace and with a sense of urgency towards creating our shared system inequalities plan. So, and then to agree the summit's priority areas, which I'll say again, which was to better share data and insights, to agree working towards and embed a shared understanding and delivery of a community-centred approach, to work together to better share resources, and to consider all policies, strategies and action plans through an inequalities lens, all with a draft plan, ideally towards the summer, to be formally signed off by the September of this year. I'll pause there, Chair. Thank you.
Okay, thank you very much. I'm sure it was a fantastic day. Unfortunately, I couldn't get a ticket. Hottest ticket in town, wasn't it, really? Has anyone got any questions or comments on the back of that? Yes.
Hi, I'm Maggie Bailey from Coping with Cancer North East. We're a small charity in Northumberland. But I'm here today representing the Health and Wellbeing Network, which is a group of over 80 VCSE organisations in Northumberland, all different sizes and shapes and from different communities. But our focus is all very much on health and wellbeing. And we were very disappointed that we weren't invited to this event, especially when it was billed as a Health Inequality Summit. Looking through your paper, we are delighted that you are recognised that you're at the emerging stage, and that perhaps we should rename it Emerging Together rather than Thriving Together as a brand. We applaud that you recognise that there is a culture change required amongst statutory organisations to work with the VCSE sector on an equal basis. So having 62 officers present at the event, we would like to ask which select invited organisations from VCSE and what basis they were. There was a few, we appreciate that. But we want to express our disappointment that wasn't an open invite, especially when asset-based community development, and I've been very involved with that in Newcastle and North Tyneside, and I'm so glad now Northumberland's trying to wake up to that. We've been doing it in Newcastle for over 10 years. It's all about participation, not representation. And we weren't allowed to participate. And we've got to express how disappointed we were in that. So, leading on for what you're asking this board to do today, the task group, who are going to be the members? How is that going to be representative of an equal participation of who's going to be involved? So it is bottom-up, community-led, not top-down select few. And that, when you're talking about immersive experience, you know, who out of those 62 delegates had lived experience of what you're talking about? And we would question the majority not having lived experience. And so really, we would suggest that you rebrand it to be Emerging Together, and you look at having a full, proper health inequality summit that feeds into regional and national policy, which has got the community involved. Thank you.
First of all, I do apologise that you weren't able to attend the event and take on board all of those comments that you have made. We, as I mentioned before, we restricted our numbers because to be COVID safe, and we did say that there was trying to be equal allocation across NHS, local authority, private sector, VCS. So we did have, as you've highlighted, and I can share with you the VCS that were in attendance at the day. In relation to the planning of the event, then we've worked very closely with Abby Conway from Citizens Advice, and we took advice through our Northumberland Communities Together partnership as to who best placed to attend. We were always going to disappoint some people, so I do apologise again, and I hope you appreciate appreciate that this is the start of the conversation, and that was about how we then go into the wider locality events that aren't about being diluted. It's about then extending and having richer conversations again out into the community. So I fully take that on board. I think in relation to the task group, that's for discussion today around the Health and Wellbeing Board table. And I think the other point that you made around immersive experience, we fully appreciated that it wasn't an opportunity for direct community members to attend, but what we had was video injects. So we had the likes of the Forget Me Nots Association. We recorded and had them as a 5-minute inject video. We had a young gentleman called Aidan, who's been through his own life experience, and he shared his experience via video link for us on the day. So it was about trying to get to have those insights. We had frontline teacher come and talk with us from Bede Community School around his experience of working with young people in that area. So fully appreciate it wasn't, if you look at the word in the truest sense, as in fully immersive, but we tried to enable the senior leaders and influencers that were there to have some insight into the real world and the strengths of those people to be able to then feed into the workshop discussions.
Thank you for that. Yeah, Graham.
Thank you, Jill. I take on board everything that you've explained. I'm sorry that you feel disappointed that you weren't asked to come, but I do need to thank Jill for the amount of preparation and planning that did go into the event. And it wasn't through lack of thinking very carefully about who should and could be on the invite list. I was on a table and there was a member of the voluntary sector on our table, and they certainly contributed with lived experience of what was going on in their community. So that voice was in the room on the day, almost certainly. Really well explained about how we need a cultural change around how we think about these issues. And for me, it is this system thing, and it's about how we get this type of thinking and way of looking at communities and way of considering inequalities into our world of commissioning and provider collaboration to try and make sure that the bottom right-hand triangle of the services actually start working with rather than doing for. And I think we can all imagine that in the world of services, in a world of COVID, when often people feel overwhelmed, we tend to look at the needs of the people and see our communities as the people who have the illnesses and the problems which are coming to us, and we react to that. And what we have to do is get to the other side of the fence and find out how we as a group can look at all the wider determinants and look at how we fill the space between services and communities as a group of services and to the wider system as well. In Northumberland, the place where our providers all come together at present is this System Transformation Board. And part of our work now needs to be to continue the compelling argument, really, to go to that board and say, we challenge you with this ambition to make sure that we start working with these considerations and we all sign up to that way of working. And the voluntary sector is obviously a really important part of that. So thank you very much, but lots of work to do. It's just a start, isn't it, really? Yeah.
Yes, thank you very much. I would also thank Jill as well, because she did a fantastic job. It wasn't about health inequalities only. It was the Inequalities Summit, because we felt that we had to try and understand, as a political administration, a bit more about what we can actually do in a world that is already really well served by professionals, but what more can we do together? Across a whole range of areas, like food poverty, child poverty, and so on. So it was simply not possible to invite everybody we would like to have, but I know that Jill has this plan to move on now, working in a more local level, to do the really hard work now, to get an action plan ready. And when you said hopefully summer, I really would like it. Yeah. I mean, if we're going to make a difference this year, it has to be done by, it has to be done really absolutely latest by September, so we can start looking at the budget and making any provision. I suppose the problem, the worry I have in the back of our mind is that that it is absolutely essential we get on with this work, given inflation, given cost of living, is going to actually accentuate the problem. But in a way, we're going to have the same problem as a council because we've got the same pressures building on us. You know, with inflation, with the cost of fuel, the cost of running our services. So I want to make sure that we get a plan that will actually make a difference, given all of that, but in time for September. So we can phase any work through the next year or two. But again, I thank Jill very much, and Liz too, and everybody that was involved, because it was really good meeting a lot of people that I didn't know, and who do so much good work. So this is not us saying, we're in charge, we want to make a difference. This is us saying we think what you're doing is great. We just need to have some clear messages in simple language that I can understand, that what we can actually physically do to make a difference.
Okay, I've got Liz Morgan.
Thank you. I mean, I think the leader makes a really good point about the fact that it was an inequalities summit, not a health inequalities summit, because I think one of the things that has come to the fore over the last well, not just last few weeks, but a sort of recognition that we need to shift our thinking about what health is, because the pervading sort of theory at the moment, or pervading view at the moment, is that, health is just a lack of ill health, and that to stay healthy, it's all about personal responsibility and the choices that you make and how you access healthcare services. Whereas actually, by focusing on inequalities rather than health inequalities, that really puts the focus on the wider determinants as the building blocks of having a healthy life. And so I think there is a bit of work for us to do as organisations, and with the public as well, to just change our perception of what health is and what creates a healthy life.
Okay, yes.
I always forget my voice isn't quite as loud as I think it is. I think from the Health Watch perspective, it was a very interesting day. I think for me, what I really valued from it and took from it was watching and working with other people and seeing some light bulbs start to go on amongst different groups, and those connections start to be made. I think for me, the question I've still got coming out of it is the thing that you said, which I thought was absolutely brilliant to hear today, and I want to hear more about this particular bit really, is the importance of citizens' voice. I mean, you obviously as Health Watch, we are going to say that around the health field, but generally, I think that's going to be the key to it. So how that ambition is written very large and very heavily into the plan, I think is going to be really important. But yeah, well done.
Yes.
Just to say, I totally agree with everything you say. I think it was a wonderful day from what I've heard, and that those who were present had some real education and some real, as Derry said, some real light bulb moments. And I think that is fantastic and very, very valuable. And I just think there's some lessons learnt about what could have been done slightly better, and hopefully that will now be put in. So it's the key adage, isn't it? Do it with us, not to us. And that's hopefully what will be taken forward in the task groups. And I do understand the timescale. Thanks.
Okay, any more questions or comments? I can't see those. I don't think we've got a recommendation as such other than work will carry on, isn't there, really? So I suppose we're just to note that, and thank you very much for everyone's comments, and thank you for organising, and I'm sure there's further work to go on, so we'll take it from there. Yes, Graham.
I just wonder if we need to agree which meeting we're going to bring this back to. I think I would be thinking September, with setting ourselves a challenge to work this through our system and come up with a more formulated plan at that point.
Yeah, well, I can see there's some recommendations there, which
So is that
which contradicts my comment that there's no recommendations. So, are we happy with those recommendations, shall I say?
I mean, we may be able to bring a verbal update into the July before the summer break, but just a verbal update if you'd like to see how we're progressing with plans, and then to bring the draft the plan in, the actual inequalities plan in for September.
Okay, right. Are we all happy with that? Fantastic. Thank you very much now. Thanks for the presentation. And I'll go back to the agenda. And the next item on the agenda is the Child Death Overview Panel CDOP annual report from Alison Johnson. Alison.
Hello. Morning, everyone. My name's Alison Johnson, and I'm the interim designated nurse for Safeguarding Children with Northumberland CCG. And this is, I've just put in a brief summary, really. This is the Child Death Overview Panel annual report for March 2020 to March, from April 2020 to March 2021. And this is the first annual report of the North and South Child Death Overview Panel. They come together to comply with the new child death review arrangements which were published in 2018, so that widened the footprint. And it contains a summary of the activity of the panel, which represents the areas of Gateshead, Newcastle, Northumberland, North Tyneside, South Tyneside and Sunderland, which includes 5 CCGs and 6 local authorities. It's part of the statutory task of the CDOP panel, which is a multi-agency panel, is to scrutinise the circumstances around each child death and, where appropriate, to provide agencies involved with any challenges, of the outcomes of the deaths. So from this CDOP review report, it includes the deaths of the children that were reviewed in 2020 and 2021, regardless of when the child died, but it was for each area. In the CDOP panel, they looked at the causes of death, identifying any contributory factors and any unmodifiable factors, so those which can be changed through any national or local interventions. The report did acknowledge that it had been a challenging year due to COVID-19, as well as it being a reconstituted panel with the combining of the north and south of Tyne CDOP, but that the virtual meetings and the use of the eCDOP, where they can share the information electronically, had gone well, and the panel met about 8 times within this time period of the report. So the total number of deaths during this review, there was 82 in total, of which 20 child deaths were in Northumberland. And of those 20 deaths in Northumberland, 9 of them had modifiable factors. Now, these weren't included in the report, so I had to go back to the CDOP chair and ask for what the modifiable factors were for the children who died in Northumberland. And these included maternal smoking, parental drug misuse, high maternal BMI. There was also 1 child who hadn't received flu vaccine, and also there was a late pregnancy booking, which also included drug misuse and alcohol misuse. And within Northumberland, there are interventions ongoing to support things like, maternal health during pregnancy, looking at substance misuse in pregnancy, and also we have rolled out ICON, which looks at reducing the abuse of head trauma and also safe sleep. So out of the whole geographical area, the highest category of death was within the first 27 days of life, so the neonatal period, that was the highest. The report also includes examples of actions that's been taken across the area to reduce child deaths. An example of which for Northumberland was following the death of a young person who had ingested MDMA, which highlighted the lack of first aid knowledge amongst young people. And the substance misuse team worked together with public health to deliver sessions across schools to recognise the signs of substance misuse and first aid. And I have, that's just really a summary of everything, and I have included the full report. I think going forward, what I have asked for from the chair was if, you know, could be a breakdown of the modifiable factors and the ages for each area, because that gives us a bit more substance of what to work on, what areas to target.
Okay, thank you very much for the presentation. Do we have any questions on the back of that? Yes.
Sorry, Alison, thank you very much for the report. I was just a point of detail. Are the deaths attributed to the place of death or the place of residence of the family?
It's place of residence. It's where the child lives.
Right.
Where their residence is.
What
yeah.
about neonates who never get out of hospital?
It's where they're where they would be registered. I would have to double check.
No, it's just
where
in terms of the,
parents live,
the interpretation of the numbers, because the numbers cluster around the neonatal units in our area, and it was just a point. It was just a point of fact when we're interpreting and looking at them.
I was wondering why North Tyneside and South Tyneside look so low, and I'm guessing that's possibly the same kind of thing.
Yes, because the two big neonatal units in Newcastle look obviously.
Yeah, no, but I would double check that, but I thought it was from where the parents reside rather than the place of death.
I mean, generally it would be, but perhaps with the neonatal units that might.
I'm just saying, if it's in the first 28 days of life.
Yeah, so they run the RVI and then sick,
So it was just in subsequent, if we're obviously distributing these messages on the health side, it would be quite helpful to.
Right, yes, I would.
Thanks very much.
Thank you.
Councillor Watson.
Yeah, just a technical question, not a very nice one. When does a child become a child? Does it have to breathe or just breathe, or for 24 hours, or is it from the moment of birth, whether it's alive or dead? I don't even know what I'm trying to get to.
It's from the moment they're born. If
so they have to draw breath to become a child. Otherwise, it's not a child.
Well, but it's still a child. It would be classed as a stillborn, I think, if not, if it didn't breathe.
That's not classed, a stillbirth is not classed as a child. That's really the question, I think.
But yeah, they are. Yeah.
I think, Jeff, what it is, these are deaths that, of children who are born and who are viable. Yes. So I don't think it includes children who are stillborn.
That's what I thought, but I wasn't sure. Yeah, thank you.
Okay, any more questions or points there? Graham, yes.
I think you touched on it at the end, Alison. So a report like this is very much a description of the numbers and what's happened. What we don't get into the depths of is the modifiable factors and the assurance that they are being adequately assessed. Now, I know that I work with you on the safeguarding group of the CCG, so I can see the processes that go on behind some of these things. But I think in some respects we just also need to think about, so are we confident that the assurance processes that are in place are working correctly? And that maybe isn't an answer to give now. I mean, you can give comment, that would be great. But I think for this board, that's one of the things that we would always be really interested to know. Well, it's essential that we know, really.
Well, within Northumberland, I would attend all the child death reviews. So once or any investigations being carried out, when they look at, it have to be a coroner's investigation, a police investigation, or whatever the cause of the death is. If there's any learning or any, any issues highlighted there, that is looked at across the board from the Safeguard and Practice Review Group, but not just that. If there's any learning from the child death reviews, that would be my role really for taking that forward within health, into linking with other agencies, or it might be with working together with a local authority. So it could bring that assurance if there was anything highlighted. For example, one week, without giving any details, there has been one this year that around safe sleep, so that we're looking at the safe sleep messages that are given out. It was a co-sleep. So.
And I think you've explained to me in the past as well about the scrutiny that occurs of the review processes too. So the review processes are assessed to make sure that we are going through those processes correctly too. So there's layers of assurance behind this.
Yeah, they're very robust, and also there's got to be a lot of assurance given of any learning that's been shared and how that's been embedded and applied to practice.
And that's one of the most important things is to, like you say, the modifiable risk factors, and make sure that the learning actually comes back into practice, and we check that it was done.
Yeah.
Okay. Thank you.
Yeah, just could I say, as chair of the Children's Safeguarding Partnership, previously the CDOT annual report came to the Safeguarding Partnership, and it was only in the last couple of years that actually that's changed, because most of the factors actually are public health related rather than necessarily safeguarding or child protection issues, which are dealt with separately anyway, although they're all included in these numbers. And it's actually something that we, as a safeguarding partnership, took on board in terms of, yes, these modifiable factors are the things that we need to really focus on. And just as an example, the safe sleeping issue, there was quite a relatively large number of issues around that in Northumberland previously, and a lot of work then was carried out with the midwives and the health visitors, and that was, if you like, a recommendation from the Safeguarding Board that interventions went into place with the health visiting service, with the midwifery service, to include all of those issues within their work. So there's been other examples of pieces of work that have gone on around drugs and so forth that has then been reported back in terms of assurance to the Safeguarding Board. And so safeguarding is a bit wider probably than child protection on its own, and therefore the Safeguarding Board has had a bit of oversight of that. Now, although it needs to come to the Health and Wellbeing Board, because these are public health issues largely, it does still come to the Safeguarding Partnership, and the Safeguarding Partnership has already had oversight of that, requested more information, and has decided that they want some interventions. ICON, which is the piece of work to reduce the impact of children, not reduce the impact of children crying, but to actually raise the issue that actually crying is normal, and therefore, give parents support and how to deal with that, with babies that cry a lot. So a lot of the work does go on. We need the report and we need that scrutiny, but we also need then to say, what are you going to do about this in terms of out there?
And one final thought, I'm just going to bring the thread of inequalities into this, because actually we've had one whole discussion about inequalities, and now we're talking about child deaths, and the two will no doubt be inextricably linked. Okay, thank you.
I just wanted to contribute. Prior to COVID, when I was working in Durham, I was the chair of the Child Death Overview Panel for Durham and Darlington, and we were and I think they're in the middle of merging now with Tees to create the larger numbers. I'm just wondering whether there's an opportunity going forward to bring the Child Death Overview Panel findings together collaboratively across the region, because again I think there's power in those messages and sharing those messages across, because I think we'll probably be finding similar factors, because we're not necessarily that different from the national factors and the mortality data set. So I just think there's an opportunity there to explore that maybe at scale as well.
Any more comments or questions? No, well, okay. Thank you, Alison, for presenting that report. Thank you very much. Now, return to the agenda. The next item on the agenda is the Health and Wellbeing Board forward plan, and that is page 61 to 68. And that's to note and discuss. Is anyone wishes to discuss on that? I can't see. So I'll go to the next item's urgent business. I have no urgent business, and the date of the next meeting is on the 12th of May at 10 o'clock at County Hall, maybe in the chamber, maybe here. Okay, thank you very much now. Thank you. Close the meeting.